This time I'd like to go ahead and call our meeting to order. Before we start with the next item on the agenda, I just want to acknowledge our guests. Again, we have Ms. Laura Busick, who is our court reporter. And we also have a Special Assistant Attorney General, Alexis Morris, who will be serving as our hearing officer. And so in proceeding with our agenda, we are to agenda item 16, which is the hearing in the case of Dr. Stephen Sutter. Right, any preliminary matters?
Yes, preliminary matters. This is a document, extensive case. The documents that the board produced, which were marked with base numbers beginning MSB and containing base numbers MSB 1 through MSB, I believe it's 1579, are the documents that we're offered at this time. There is an index on the front for patient one. There are 5 patients at issue. So we have to divide. They're not in direct numerical order from start to finish. They're divided by some relevance. There is a code. Because there's so many documents, we have only produced one hard copy for the board's use if you need it. Every one of you has all of these documents on your Surface Pro and PDF, but if you need to refer to a hard copy, that one we didn't want to kill, or it would have taken about 11 or 14,000 pages. So anyway, at this time, we would offer pages MSB 1 through 1579. If I've forgotten that last number wrong, I will adjust.
Council, I've noted your objection, but I assume you want to put that on the record as well.
For the record, I object to the board's production. The board's production representation of charts of the 5 pages at issue is inaccurate. The charts are incomplete. We've attempted to remedy that problem by copying all the charts in the manner in which they're kept to make it easy for the board to follow and for the witnesses to testify. We have reviewed the board's documents and they are not complete. They are not accurate. It is not a representation of the patient charts.
Thank you. Your objection has been noted for the record.
One thing for the record, my representation is that these are the records that were produced months ago to the other side. And so I am not maintaining that these are the complete charts, that there are not some pages missing here and there. I can't tell you that. I'm not going to tell you that. But I'm telling you the documents that we produced and that everyone has been working on the assumption would be used for months. Those documents are all in the record. So the implication that I am suggesting that the charts are totally complete in the documents, I'm not. I can't.
I'd like to add something. He's not representing this complete chart, but that's the chart that the expert, the doctor that was retained by the staff to review the records, base his opinion on. Part of his opinion says that the record, the charts are incomplete. They don't have documentation. That's the problem. They do.
Thank you so much, gentlemen. I appreciate your vigorousness about this, but I've already made my ruling. And as of now, the exhibits that the board will have to review will be the exhibits that were just admitted by the board. Any exhibits from?
Yes, the respondent tenders exhibits base number Sutter 1 through Sutter 108. Sutter 36 through 37 are the CVs of 2 of the expert witnesses that have previously been listed. Sutter 58 through 60 are awards. One is a American Society of Bariatrics and Physicians Task Force Award to Dr. Sutter and Lisa Sutter. Sutter 59 through 60 is a House concurrent resolution number 107. And Sutter 61 through 66 are the title page and the pages of the article authored by Dr. Sutter that appeared in the Journal of the Mississippi State Medical Association in March 2011, which we listed in our disclosures. And last, Sutter 67 through Sutter 108 are simply regulations of the board that has some of the regulations. I didn't try to piecemeal it, but I just copied what included the regulations at issue here for the board's convenience and for questioning.
Any objection, council?
No objection to Sutter 1 through 35, as those were produced well in advance of the hearing. I reserve my objections to Sutter 36 through 108, as those were produced yesterday. I may not have objections, but I reserve the right to object to the documents as they use.
Okay, so admitted at this time.
The respondent also proffers the documents. There's 1,066 pages, which are the charts of the 5 patients at issue here. You have ruled that they are not admissible, but we are making our proffer, and I ask that the court reporter designate those documents as being proffered, part of the record.
Thank you.
I believe it'd be proper to mark them for identification.
Absolutely. And I believe Dr. Owens has an announcement.
Yeah, just for the board's benefit to clarify, as Paul mentioned earlier, on your Surface Pros, there is a actual folder that has those documents that were submitted, since there's one like basic paper copy binder. So you do have the ability to follow along on your Surface Pros. Those have been consolidated and put together in a file. So all you got to do is click on them. And the Bates numbers that were given, the references are included so that you can follow along on your Surface Pro.
Witnesses, are there any witnesses in the room at this time? I would love for them to all be sworn in at the same time, if possible.
Yes, we have witnesses.
Okay,
And Dr. Chance is going to testify remotely, so we need to give him an opportunity. He's on a line. We need to give him a chance to.
yes, if we could pin him and if he could turn his camera on, that would be great.
I was not aware that he was testifying remotely, and I object because my client, the respondent, has the right to confront the accusers.
Right, and he will confront him on the Zoom camera today.
I don't think that's provided for in the Constitution, so I'm going to maintain my objection that this is violating his right to confront his accuser.
So noted for the record.
Can we also make sure that the record reflects that Dr. Rod Givens, who's also a board member, is present via Zoom as well?
If Dr. Chance could turn his camera on so that we can, if all witnesses would stand at this time. And Madam Court Reporter, would you swear in all witnesses at this time, please?
If you'll raise your right hand, please.
Raise.
You do all solemnly swear that the testimony you will give will be the truth, the whole truth, and nothing but the truth.
You testify. You're standing.
I'm not raising my hand.
Thank you. Will the rule be invoked?
I'm not going to invoke the rule. Not only, but Dr. Chance is an expert. He has a right to hear testimony, and so do I think that.
Okay.
I'm not invoking.
Okay, what about you? No.
Respondent does not vote.
Got it. Okay. If there are no other preliminary matters, I'd be happy to hear opening statements at this time.
So Dr. Chance, if you would, if you just mute your mic, and when it's your time for you to testify, Gerard will bring you back up. Thank you. Yes. Good morning. As you have probably gleaned from some of the pre-hearing proceedings, this is will be a contentious hearing. It is a very important hearing. Both sides are passionate about this matter, but we will, work, I know, and both of us do our utmost to present this matter professionally. The respondent is Dr. Stephen Derek Sutter, MD. Dr. Sutter practices primarily in the areas of weight loss and hormone replacement therapy at this time. The board received several complaints about Dr. Sutter beginning several years ago. This case began, I believe it was 5 years ago. The investigator who started the investigation, Charles Ware, retired, been retired for a couple of years. Bryson Pickett was the investigator who took the investigation and brought it forward. In preparing the summons and affidavit, we chose to narrow this down to 5 patients so that we thought were most the best representative issues. And we submitted those to Dr. Ricky Chance for his review. Dr. Chance reviewed those, I believe, initially about 2 years ago. And Dr. Chance, then we had asked him to, he prepared, took some written notes as he did his reviews. Those notes are in the documents, and I'll point you to the direct page number, but those written notes are in there for each patient as they're divided. His notes that he took when he was doing his record review there. Dr. Chance then, months later, if not a year later, we asked him to prepare a typewritten report for us. He did so. That is also in your materials, Dr. Chance's report. You're going to hear it referred to a great deal. Last, Dr. Chance reviewed a hospital chart for one of the patients, patient 1, and he issued a 1-page supplemental report, and it's in your folder, but it essentially says this does not, nothing in this chart changes my opinions about Dr. Sutter's outpatient care of these patients. Now, because this was so documented, obviously we had some confusion because we, the staff, and I take full responsibility, we mixed up the numbering from Dr. Chance's report. Dr. Chance had the number 1 through 5 in the order he reviewed. In the affidavit is not the same order as those that Dr. Chance listed in his report. I know that's confusing, but we're going to go with the numbering in the affidavit, pages 1 through 5. Dr. Chance, we will go to his report and confirm the pages. Again, we're talking about page 1, Dr. Chance, and we will confirm that so we don't get into any confusion about the numbers. I believe one of Mr. Mercier's experts in the report that was produced to us, expert endocrinologist, also on 2 female records, used Dr. Chance's number. So we'll do our best to clean this up together. But the basis of this case is prescribing. And the issue is whether or not Dr. Sutter, in this weight loss and hormone replacement therapy practice, acted inconsistently in accordance with professional standards for such a practice. And it is the board's position that he did not. Patient 1, 64-year-old male, out of uncontrolled hypertension, a number of comorbid conditions, was treated by Dr. Sutter and his subordinates, nurse practitioners, and at least 1 PA with phentermine, testosterone, other medications, despite normal baseline lab values for some of those medications. And we'll point you those. Patient 2, female, had baseline, normal baseline TSH and T4 levels. Patient was prescribed hormone replacement therapy. The lab test reflect male rather than female scales. But she was treated with testosterone, and he also prescribed multiple hypnotics such as diazepam and Desa in combination with stimulant diet medications. And the diet medication at issue in all of these patients is phentermine. The time frame for some of these records begins, at least for one patient, I believe in 2011, as approximately 2020. Patient number 3, another female patient filed a complaint against Dr. Sutter. Her complaint is in the materials that were produced the other side, and are in the materials in front of you. I would note that we're going to need to redact that document before so that it's not released, because her name is reflected, but she is patient number 3 in the affidavit. Patient 3 came to see Dr. Sutter in his clinic, off and on for over 7 years. She was prescribed phentermine 37.5 milligrams twice daily. That's a common prescribing pattern you'll see throughout these records. 37.5 milligrams twice daily. That's twice the package insert and recommended dosage for phentermine. Now, Dr. Sutter's experts have opined that that's normal for weight loss practice to prescribe double this stimulant. Adipex, phentermine, Adipex, same medication. That's regular practice, and it's okay. The patient was also treated with testosterone pellets, despite having normal range testosterone level. After she was treated with pellets, her testosterone level exceeded normal range. The patient had side effects, including both the facial hair, acne, had to be prescribed an additional medication to take care of those that were caused by the excessive testosterone. Patient 4, female patient, again was treated with phentermine. She was treated with a product called Armour Thyroid, despite her initial baseline lab showing that her lab values were in the normal range. Later labs indicated that her T3 was elevated, opined by Dr. Chance to be likely due to the Armour Thyroid. And at some point, this patient had been receiving testosterone in an alternate form. At some point, which we'll get to in the record, Dr. Sutter treated her with testosterone pellets. And the husband of this patient who was also a patient of Dr. Sutter, contacted Dr. Sutter, complained, said, my wife, essentially, and I'm paraphrasing, hypersexual, she is out of control. You'll see the exact note is in the record, and said, I think this is, she doesn't need to go on this medication. I'm seriously concerned. And Dr. Sutter informed the husband, that's in Dr. Sutter's notes, and said, well, I can't discuss it with her, but if she wants to continue the treatment, that's her decision. You will also see, and that husband is patient number 5, and you'll see a note in his chart, written in his chart, where it says urgent. And it says, the patient has contacted, needs to speak to Dr. Sutter about his wife. Patient 5 also had uncontrolled hypertension period of several years. He was prescribed double doses of phentermine on a regular basis, despite his blood pressures. You will see that phentermine was, at least at that time, Dr. Sutter's first-line medication for weight loss. And that's evidenced by the fact that when you start looking at these charts, there are pre-printed forms. History, physical, blood pressure, vitals. And then there's a spot for phentermine, 37.5 milligrams. And you just check the box, 30, i.e. once a day, which is the maximum recommended dosage, 45, 1.5, or 60, 2 per day. In addition to phentermine, Dr. Sutter regularly, these patients, prescribe Topamax at times. And to alleviate the symptoms of insomnia and sleep disturbances that most likely or not chance resulted from being on the stimulant diet medications. He prescribed hypnotics such as Ambien, Lunesta, Restoril. Now, weight loss practice, as this board is well aware, is a subspecialty. It is a subspecialty for which there is no board certification recognized by the American Board of Medical Specialists. So everyone on this board is aware of what that means. There are organizations that provide the American Board of Bariatric Medicine, which provides the board certification, but that is not an ABMS recognized subspecialty. So I just want the board to be aware of that. Now, Dr. Sutter, we have chosen to offer as our expert, Dr. Ricky Chance, is familiar to a lot of the board members. Dr. Chance is a family medicine physician. Dr. Chance also has background education and training as a pharmacist. And so at the appropriate time, I'll be offering Dr. Chance as an expert in family practice and general medicine. But Dr. Sutter has chosen to present his case, his experts, an endocrinologist and a bariatric specialist. And as they testify, and as you hear the evidence, I want the board to consider that Dr. Chance is approaching these patients from a holistic view. He is looking at the entire chart. He's looking at all the medications. He's looking at the interactions of the various conditions, the various medications. He's not just looking at hormones. He's not just looking at diet medications. That's what Dr. Sutter's experts do. His bariatric specialist says, I'm only going to offer opinions about the diet meds. The endocrinologist says, I'm only offering opinions about the hormone therapy. But the issue, as Dr. Chance will testify, in most of these cases, if not all, and most of his complaints deals with the combination of those medications, both the hormone replacement therapy in combination with the diet medications. So ask the board's patience. This is a case, it's document intensive. There'll be a lot of references to the chart. But at the end of the day, I believe that our evidence will show that Dr. Sutter is guilty of each of the counts specified in the affidavit. That Dr. Chance's testimony supports and confirms that the board has met its burden. And Dr. Sutter and his witnesses and experts aren't going to change that. Thank you.
Good morning, Madam President, ladies and gentlemen on the board. I represent Dr. Stephen Sutter in this matter, as you know. Mr. Barnes was right that this is an issue about weight loss and bariatrics and hormone replacement therapy and treatment of thyroid mutation. But he tries to tell you that the specialists that do that are not the ones that are more qualified to discuss these issues and testify about treatment of patients, that a family medicine doctor is more qualified than the people that have the CME requirements that this board imposes on people who treat patients for weight loss to have a bariatric clinic. I disagree. I think the board disagrees based on the regulations. This case was brought by a summons sent to Dr. Sutter by the executive director, Dr. Ken Cleveland, and an affidavit that was signed by Mr. Bryson Pickens, investigator. Mr. Pickens makes statements in here that he attributes to Dr. Chance in the report that Dr. Chance provided to him. Some of the statements in this affidavit apparently don't come from Dr. Chance. And we're going to explore those and demonstrate the errors both in his affidavit and in Dr. Chance's report. The burden of proof to prove these things in this affidavit, which accused my client of violations of the law, is on the staff. It's not on my client to come in here and prove to you that he is innocent of these charges. The burden of proof is on the prosecution always. There's always a presumption of innocence on top of that. Dr. Sutter is innocent. Dr. Chance, like everyone else, is entitled to his opinions. But his opinions don't make it law. And opinions have to have support, to be credible, and to be relied upon. Anybody can say anything about any physician. According to what we're hearing, someone not in a specialty being practiced by the board members here could be given charts to review of your patients, but not in your specialty, and come in this board and testify before you and tell you, your peers, that you have violated the law without any published articles cited to for support of his opinion. He's entitled to his opinion, but he doesn't have support for it. Without that support, he doesn't meet the burden of proof. The board staff is also asking you to rely upon an incomplete chart. As I said earlier, you heard, we have copied the chart. My client's going to refer to the chart, the actual chart. The chart, or 5 charts, were acquired by the board investigator from Dr. Sutter's office, from his wife, Lisa Sutter. She gave them the charts, the complete charts. But upon review in preparation for this hearing, reviewing those documents, they're not complete. But what my experts have relied upon, or Dr. Sutter's experts and Dr. Sutter, are the actual charts. That's where the information is, the documentation is, that's where the proof is. The opinions that you will hear will come from experts in the field of endocrinology and bariatrics, as well as family medicine. And you will hear the complete comprehensive approach to treating these patients that Dr. Sutter takes. It's not a pill mill, as Mr. Barnes is trying to make it appear. That just shows a lack of understanding and a lack of education about medical science in this area. Mr. Barnes said there were several complaints. He listed two complaints. One was from a patient who filed a complaint. She said that Dr. Sutter was giving her something that she thought was bad for her. She thought it was an amphetamine, but she continued to see Dr. Sutter. When that complaint was filed in 2019, Dr. Cleveland didn't call Dr. Sutter, didn't send him a letter, didn't send him a complaint, didn't say, come in, let's talk about this, come before the executive committee. Didn't hear anything. This thing sat there for since 2019, But he's trying to tell you that Dr. Sudderth is a danger to the public. But he's let this case sit there since 2019 for somebody he says is a danger to the public. 2019, excuse me. Dr. Sudderth never had a chance to address this issue with the board or with the board's executive committee before it got to the point it's at today. There are safeguards inside the board's rules to prevent things like this from happening. Those safeguards were not followed. There's a procedure. Part of it's called due process. Due process is embodied in our Constitution and in our laws designed to protect citizens and their property interests like their license. The due process includes this board's rules. Those were not followed. Let me go ahead and jump to it. The other complaint that was mentioned is from the husband of one of the patients, who was also a patient. That husband, which I don't know if Mr. Barnes informed you, is a physician. So that physician had gone to Dr. Sudderth to be treated. And his wife was being treated by Dr. Sudderth. What he didn't tell you is that physician was also treating his wife, according to the PMP that the board produced to us. That physician was ordering testosterone for his wife. But what's worse is Mr. Barnes pretends that a man who is a doctor and husband of a woman can call up her medical provider and say, I want you to stop treating her. I want to control her life. I want to control her medical decisions. She can't do it for herself. That's what he's telling you. If you're reading the record, Dr. Sudderth's response to that physician was, I cannot discuss it with you. It's a HIPAA violation. I will address it with my patient. It is her decision. I don't think any of you would respond differently. A lot of what you have here are misconceptions, misconstructions, a lot of assumptions that just aren't there. Mr. Barnes implied to you a few minutes ago, and I want you to remember this, because this goes to credibility of this case and everything they're saying. He implied to you that my client, Dr. Sudderth, was prescribing phentermine to patient LS. Look at the records. He was not. He did not prescribe that. It was another medical provider with that clinic. It was not him. He was not treating her for that. The prescribing by Dr. Sudderth was compliant with the regulations. The regulations here at issue are 1.4 regarding documentation and 1.5 for the prescribing. That's part of the documents that I provided you in our binder in the Sudderth base number documents. He was completely compliant with those regulations. And what Mr. Barnes didn't tell you is that Dr. Sudderth co-authored those regulations in 2012 with this board, with Virginia Crawford and Randy Easterling and other members of this board that period. He co-authored them. Dr. Ryman also assisted this board and testified before this board in drafting those regulations. Mr. Barnes was not with this board at that time. Neither was the executive director. These people know what the intent was of those regulations and know what they meant. Dr. Sutter's treatment of his patients was compliant with the regulations. It was proper. And as required, it was based upon good medical science and sound clinical judgment and practices. You will hear from experts in those areas of practice. There is confusion in the way the affidavit lists the patients and the way Dr. Chance lists them in his report after his review. What we have tried to do is, in discussion, is refer to these patients by their initials. None of them have the same two initials, which to me would make it a little bit clearer for the board members and the witnesses and the attorneys about which patient we're discussing, because a patient 2 in the affidavit is not the same as patient 2 in Dr. Chance's report. It's not the same in my expert reports either. So we'll handle it any way that you want to, but that's just my suggestion, is that we try to refer to the patients by their initials. Thank you.
Complaint counsel, calls Dr. Sutter to the stand.
And please let the record reflect that Dr. Southern has already been sworn.
Good morning, Dr. Sutter, and I will be referring, I see you have a lot of pages and charts there. And I just want to let you know that I'll be referring to the base numbers charts, the ones that have bear the base numbers beginning with MSD, and I'll point you to some specific pages when necessary. Dr. Sutter, if you will, could you please provide me the benefit of your education and training as a physician?
Yes, went to medical school at LSU in New Orleans. Did my internship at Yale affiliated hospital, St. Raphael in Connecticut. Did my general surgery residency in University of Nevada. And started my practice in general surgery in '94. And then moved to Vicksburg, where I continued general surgery as well as bariatric surgery. And in 2008, becoming interested in bariatric medicine, and became board certified in bariatric medicine in 2011. Have been retired from general surgery in 2016, and primarily do medical weight loss now and hormone replacement therapy.
Okay. What is BioT?
BioT is one of several companies that produce testosterone in the form of pellets. These are inserted into the body. When I first got into this in 2016, there were only about 8 providers in the state. Happy to say that there's now 34 BioT providers in the state, and probably hundreds more using other types of pellets.
You're a BioT certified physician, is that right?
Correct.
Okay. What did you do to become a BioT certified physician?
Well, you had to, of course, attend the 2-day course. You have to pass a written exam, and then you perform procedures to become certified. That's monitored by the proctors.
Do you have a relationship with any other producer or manufacturer of hormone supplements?
No.
just BioT. Your expert, Dr. Bryant, does he have a relationship with BioT?
I'm sorry, could you say that again?
Your expert, Dr. Bryman, am I pronouncing it right?
Yeah.
If I've gotten his name wrong, I'll apologize. He has a relationship with BioT, correct?
No, sir.
He doesn't. He does no connection with BioT. What about the endocrinologist?
Yes,
Does that Dr. Cassie Smith?
yes, sir.
Okay, so she has an active relationship with BioT, the company.
Yes, I believe she's on the faculty of biotech.
So Dr. Sutter, as I understand, your testimony, since 2016, when you retired from surgery, you have focused your practice on weight loss and hormone replacement therapy, correct?
When I returned from where?
When you retired from surgery, I'll try to speak up.
I was doing I was doing medical weight loss. You see, I kind of came into this backwards. This is usually started by primary care doctors that then get into bariatric medicine. I kind of came at it backwards. I came at it from the point that from bariatric surgery. So I was getting my patients actually ready for laparoscopic bariatric surgical procedures, and I needed them to lose weight. This kind of clinic started to take off on its own, and many patients didn't want to get the surgery after we got them to lose weight. And this kind of clinic got bigger and bigger to the point that I realized I needed to educate myself better in the field of bariatric medicine. And that's why I became a member of the ASBP, the American Society of Bariatric Physicians, which then turned the name changed to the OMA, which you may be familiar with today, called the Obesity Medical Association.
And I did not mean to imply that you had not practiced bariatric medicine before. I just meant that since you retired, well, let me ask you, what year approximately did you start practicing clinical bariatric medicine?
Probably around 2005, where I was starting to get my patients ready to undergo surgery. And this, it's crudest form, trying to get them.
Yes, I understand. And when did you open a new clinic for your bariatric medicine practice, or was it an outgrowth of your surgical practice?
Well, when I started, I was on staff at the hospital, and I was an employee of the hospital, at River Region Hospital in Vicksburg. Then I went on my own in 2009, and in that clinic, and I did general surgery, bariatric surgery out of that clinic, as well as bariatric medicine, and then opened a second clinic in Ridgeland.
Excuse me. And then again, approximately 2016, you retired from the practice of surgery and focused on the medical bariatrics and hormone replacement.
Yes, sir.
Okay. Now, in your two locations, do you travel between the two locations?
I do.
Okay. You have a number of mid-level providers who have worked with you over the years, and several who work with you now. Is that fair?
Yes, sir.
Okay. What type, do you have nurse practitioners or PAs or what?
Well, I started off with nurse practitioners, but there was limitations to what nurse practitioners can do in a weight loss clinic. They can only see patients for 3 times in a calendar year for weight loss, so that doesn't help me that much. So I moved to physician assistants, where they are under the control of the medical licensure, and they can practice year-round in bariatric medicine.
And physician assistants, excuse me, they're more of like physician extenders, right? They are an extension of your practice. You
Correct.
direct them. They have to practice under the supervision of the physician. They can't set up an independent practice in their own clinic like a nurse practitioner.
I'm not sure if they can practice on their own or not, but in my clinic, they are independent of me. They have their own patients. I don't walk in the room with them every single time. They can practice on their own. They're independent thinkers. They have their own DEA licenses. I taught them all about bariatric medicine. And when I felt comfortable that they could practice on their own, they do that.
And you're registered as the, do you still use any nurse practitioners?
I have one nurse practitioner, but she doesn't do medical weight loss.
Okay. For your PAs, you are, the registered supervising physician for those PAs?
I'm the collaborating physician, yes, sir.
Well, I apologize, yeah. Semantics. About collaborating for nurse practice and supervision for PAs, but right. So, but you are the physician that they collaborate, work with. So what do you do, in connection with your supervision of your PAs? To be in accordance with the board's regulations concerning such a relationship?
Well, I have to do QA on their charts, which is typically about 10%. I'm always available for any questions they have, regardless of what location we're at. I'm usually in the clinic with at least one of the PAs at any given time. That's about it.
Okay, and you do, quarterly, reviews, quarterly meetings with your PAs?
We do, service for, seems like I'm doing them constantly, but I think it's monthly.
Okay, well, the regulations call for monthly chart reviews, which you said you do, and also then quarterly meetings, which are more QA oriented. And is there an educational component to those meetings? So I'm sorry, I didn't mean to talk over you. Where you would address any issues you saw in your chart reviews, right? If you disagreed with what the PAs were doing or thought there was an issue that needed to be discussed, you would raise it with them.
Always.
And so your attorney has pointed out that some of the medications, a lot of the times, medications were actually prescribed by a PA to some of these patients at issue, but you also saw these patients, did you not?
Yes, sir.
Okay. And did you see, did your prescribing or analysis of these patients differ in any significant way from the evaluation, assessment, and treatment that your PAs performed with these patients?
Of these particular 5 charts?
Yes, sir.
No, sir.
Okay. And in fact, there are patients, and we can go to the specifics, but there are patients where you prescribe, phentermine twice daily, and then your PAs prescribe exactly the same medication, right?
They prescribe it as they so feel comfortable with doing.
But you set the tone and the standards for your weight loss practice, do you not?
Object to the form, he's talking about the standards, the regulations of the board of standards.
Any rebuttal, counselor?
I'm trying to determine exactly what Dr. Sutter's supervision of his mid-level providers consists of. And who determines how the practice is conducted.
Overruled.
Dr. Sutter, if the PA practices in a manner that is inconsistent with what you consider to be good medicine, do you keep that PA on your staff?
It depends on what the infraction. If it's minor infraction, I would, okay? If it's a major infraction, that would be up for discussion between me and my clinic manager, as well as the provider, whether I kept them on staff.
But if you had a major medical difference of opinion regarding, say, the prescribing of phentermine, the appropriate dosages, or the prescribing of hormone replacement therapy, would you continue to keep a mid-level practitioner in your practice if you differed significantly from their view of the appropriate approach?
No, I would not.
What is controlled blood pressure? Controlled hypertension.
Controlled would be, well, it's better to give the opposite first. So uncontrolled by definition, the strictest definition would be greater than 140/90. So basically under that, we could call it controlled.
So the American Heart Association says that controlled hypertension is anything less than 130 and less than 80. So you disagree with that?
No, I'm not necessarily, I'm not sure of their classification of it.
Well, So if the American Heart Association says that anything over 130 or anything over 80 is stage 1 hypertension, would you disagree?
No?
And you would agree that even though it's not classified as hypertension, blood pressure is in the range of 120 to 129 systolic, and less than 80 still can be considered elevated. Which, correct?
At what level?
120 to 129.
Pretty hypertensive.
140 systolic or higher, 90 diastolic or higher, stage 2 hypertension. Would you agree with that?
I would call that uncontrolled.
And higher than 180 systolic or higher than 120 diastolic, hypertensive crisis. That's an emergency situation. What, I'm sorry, 180 systolic and or higher than 120 diastolic.
Yes, I'd classify that as malignant hypertension.
Serious emergency at that point. A serious emergency at that point. By the time you get that, you were in a crisis.
Yes.
Let's talk about testosterone replacement therapy for a bit. What forms does testosterone come for as a medication? Powder, liquid, pellets? What are the various types, delivery mechanisms?
It can come as a pill orally. It can come intramuscular.
Injection.
What's that?
IM.
You can also give it sub-Q. You can give it as a transdermal. You can give it as a sublingual.
So just hang on a second. Dermal, skin, sublingual under the tongue.
Correct.
Okay, thank you. Continue, please. I'm sorry. I'm just
As
making
well
sure.
as in pellet form.
Well, let's talk about the pellets. Is that the primary form of testosterone that you use in your hormone replacement therapy?
I would say in males, it's 50-50 whether patients want to use intramuscular, sub-Q, or pellets. And that's for a variety of reasons why males may choose a different route, but primarily in females, that's the number one route that females go, is the pellet.
And why is that? In your opinion?
Yeah, so males may choose to use a pellet, intramuscular, because maybe they only have insurance coverage for intramuscular injection, and or they may not know anything about pellets. So many males, because of the cost of a pellet, it may be prohibitive for them to use a pellet, so they typically will choose IM injections. Females typically choose pellets because, well, they're not typically as desperate as maybe a man may be who gets testosterone. There's probably in the male, there's probably some erectile dysfunction that goes along with that. And he's going to do whatever it takes to increase his testosterone to cure that problem. Whereas in a female, they're not willing, in my opinion, to intramuscularly inject themselves every week, 2 weeks, or monthly. It would just be easier for them to use a bioidentical hormone pellet that has less side effects. And the length of time it works is 4 months versus 1 week, 2 weeks, 1 month.
You said less side effects, but it's I understand the mechanism when you insert pellets. Would you describe that? What's the mechanism for using pellets?
A pellet is just, listen, it's another delivery method that you can deliver testosterone. In my opinion, the delivery method of a pellet is much better because it gives a very steady state of testosterone in the person, much like they were when they were younger and had functioning ovaries and testicles. Whereas and it doesn't have nearly the side effects as an injectable form does. Injectable forms have to be dosed in a male weekly. That is putting their testosterone very high and very low in a week's period of time. Whereas a male testosterone pellet works over 5 to 6 months. Okay, so it's a very gradual, it's much more like the human body of how it secreted it when they were 20 years old. Does that answer the question?
Enough, but what happens if you use too high a dose of pellets of testosterone and you implant them in a patient? And you test their labs later and the testosterone level is extremely high.
Okay, so the way that you come about to the dosing, okay, there is in BioT an algorithm that you use, and you pretty much put the patient's age in, their weight in, their testosterone levels when we start in, and some other factors. And no matter what BioT provider you are, everybody's going to use the same algorithm to dose the patient. Okay? Dr. Cleveland used the same pellet as I did. He would have done the same dosing as I did. So that's how you come about the dose. Now, if the level goes higher than you want it, in a male, we typically want the 4-week peak level to be somewhere between 900 and 1100. And for females, we want that peak level at 6 weeks to be somewhere between 150 and 250. So for instance, if it goes high, it's not a problem. You don't have to freak out. You just simply push the pellet out a little bit further to let the level come back down and to dose them at a lower dose. If there's any particular side effects that they're having because the dose is too high, which is, I've never really run into a problem of testosterone level being too high that a patient disliked it. I just wouldn't want to keep them at high levels because then they can produce so many side effects.
Right, because if you give a male menopausal man testosterone and you get it up to 1400, he's likely to feel better, right?
He's going to feel much better.
Okay, that doesn't mean that testosterone level is necessarily safe for that patient, does it?
Yes.
Depending on their comorbid conditions.
Yeah, it's perfectly safe. Okay, you wouldn't want to keep it at 1400 for the sole reason that their H&H, their hemoglobin and hematocrit may rise too high, and then they might have to go donate blood. So you wouldn't want to keep it high.
And again, well, at some point you say you wouldn't want to keep it that high because of side effects. What type of side effects?
Well, are you referring to a male or a female?
A male.
Well, there's very little side effects in a male except that their H&H may go too high.
No mental, emotional side effects that can come from an
No,
excessive high testosterone.
that is an absolute myth. And that is because, sir, that comes from where weightlifters and football players would inject their testosterones up to 5,000 and 6,000, and they would get something called roid rage. That doesn't happen at normal testosterone levels. It actually does the opposite. The patient is much more calm and less moody, less irritable with a normal testosterone.
Let's talk about normal testosterone. And understand, or it is my understanding that the range varies with the age of the patient to some extent. Is that fair?
No, there's no difference.
Okay, well then what's the normal range of testosterone in a healthy man?
It changes from lab to lab, but in my particular lab, it's typically from 280 to 1100 is what's considered a normal level.
So you would expect a patient off the street who does not have low T to have if you tested their testosterone, did a lab for their testosterone, you would expect their value to fall somewhere between 280 and 1100.
Yes. So age does have a play in that though. Okay. So if you are a younger male, 18 to 25 years old, the reason we got normal testosterone at 900 to 1100 is because the boys went off to Vietnam in the 60s and we checked their testosterone levels, and it turned out that 900 to 1100 was the range of a young male. So that's what we still think of today as a normal male range at 20. But If you are 60, you may fall within the normal range, but you're on the low side of normal. Suboptimal,
Suboptimal.
correct, sir.
But that is normal, the normal aging process, isn't it?
It is. Testosterone decreases 3 to 5% a year.
Okay, let's talk, briefly about phentermine. I understand, phentermine is not technically an amphetamine, but it is a stimulant, is it not?
It is a mild stimulant,
It's a controlled substance.
Schedule 4.
During the time, for the medical records that were produced by the board and they're in the record, phentermine appears to have been your first line medication or frontline medication.
It varies from patient to patient. I'll use a variety of different medicines that are FDA approved for weight loss. Phentermine is popular. It's still the #1 weight loss medication in the United States since 1959 because it's very safe. It is highly effective, and there aren't a lot of adverse side effects to it. There are minor side effects, but that's about it with phentermine. So it's has a good drug profile that you can use safely. But diethylpropion is like phentermine's little brother. It doesn't have as much stimulant effect as phentermine does. So if the patient has an adverse side effect of too much stimulation, you can go to diethylpropion. Bontrol, which is phendimetrazine, and Diedrex, they're all in the same classifications as phentermine is. They're stimulant type drugs, typically called indirect sympathomimic amines, not amphetamines.
Does your office use pre-printed forms for your weight loss patients?
Yes,
Okay. The only medication that's listed by name on that form is phentermine, isn't it?
well, it has a line underneath it for written prescription.
Right. Well, I do it.
So if we had a change of phentermine, it would go in that line.
Understood. But if you would, just for example, let's look at MSB 677.
What number is it, please, sir?
677. John, we'll get you.
We bring him a bottle of water, please.
I apologize. Anytime. 677.
Yes.
And I apologize. Let's back up to 662, 662. I apologize. We're getting, all right, I just some water. And thank you.
Do we have this on our
Yes, sir.
iPad?
Thank you.
So what I want to ask you about the difference in some of the forms of records that appear in the medical records.
Yes, sir.
So this is dated 6/11/15, correct?
It is.
Okay. Shows a blood pressure of 162/92. Is that controlled hypertension?
No, that's uncontrolled.
Okay. Am I correct that this, and if you flip back a couple, this appears to be like your, like an initial intake type, forms, if you flip back to page
Yes, that's-
658,
I'm sorry, can you show me?
658, just
658.
just flip back. This is like initial type documentation, is it not, for your weight loss
It's
patient?
registration forms for the patient.
Okay. So now, if you flip over. To 677. If you flip to page
677.
677.
Okay, sir.
And I apologize, that is the first one that I had mentioned, I just wanted to. And this appears to be, and once you, have you got that page?
Yes, sir.
This is a form for follow-up business, is that right?
This is a follow-up visit point.
Okay, so, this date, 7/18, I'm not sure if that's 13, maybe 7/13/15.
Yes, sir.
Blood pressure is 153/67,
Yes.
okay? Well, the 67 is a good number, but 153 out of control hypertension, correct?
Uncontrolled.
Uncontrolled, thank you. Thank you, I apologize. And at the bottom of the page, where it says diet medication dispense, phentermine, 37.5 milligrams. That's typed in, that's not filled in later, that comes on the form. Is that
Yes.
right? And then you check the box, 30, 45, or 60.
Yes, sir.
And if you prescribe 30, so 37.5 milligrams of phentermine, you would agree with me that per the package insert, that's the recommended maximum dosage of phentermine by the manufacturer, correct?
Yes, that were written in 1959.
Now, if you would, and I know you're experts, explain to me why it is, your common practice and why it is safe to regularly prescribe twice that, 2 times a day, 37.5 milligrams, sometimes you prescribe 45, that's 1 pill in the morning, half pill in the afternoon, correct?
Correct, sir.
And other times you prescribe 1 pill in the morning, 1 pill at night. So that's,
1 pill in the afternoon.
I'm sorry, 1 pill in the morning, 1 pill in the afternoon, but a total dosage of 2 pills per day, or whatever 2 times 37.5 milligrams is, correct?
That's 75.
Okay, so why is that appropriate and why is it safe?
Okay. So the guidelines that were written in 1959 about phentermine, back in those days, they didn't really see obesity as a chronic disease that we do today. So they only did short-term studies on the drug. And the maximum length of time they did was about 12 weeks, sometimes 8 weeks on certain drugs. But in 1959, it was about 12 weeks that phentermine was done the studies on. So that's what they approved it for, 12 weeks. Pretty much every bariatrician and any other doctor that uses phentermine today is going to be using it off-label in that respect, because most licensing boards now, including Mississippi, there is no length of duration any longer as a prerequisite to use the drug. It has been studied for 64 years now, and we now know absolutely that phentermine can be used safe and effectively for longer than 12 weeks. And in Mississippi, it's year-round as long as the patient qualifies. That's what the rules and regulations said in 2012 that I co-authored with Dr. Easterling. Prior to that, the rule and regulation was that you can only use phentermine for 6 months out of any calendar year. But when we recognized, really, it became more accepted that obesity was a chronic disease and it was no different from hypertension or diabetes, it needed chronic treatment. And so that's why in the 2012 guidelines, that stipulation of 6 months out of any calendar year was dropped. Okay. The other parts about phentermine back in 1959 is they made a lot of supposition, but they didn't really do any testing on this because they thought phentermine was similar to amphetamines and methamphetamines of the day. So they said it could be abused. They said it was addictive. They said you can't use it with uncontrolled hypertension and that you were limited to only using 37.5 milligrams a day, 1 tablet. But over the years, a lot of data has come out that we now know as accepted scientific evidence and sound clinical grounds for over 60 years of using this drug. And if you wouldn't mind, sir, if I could just read a very important article about the dosing that would bring this to light a little bit better. Is that
Go right
acceptable?
Go right ahead.
Okay. So the book I'm going to be referring to. There's two handbooks that most bariatricians have in their possession, have read, or have studied from it to pass their boards. This book right here, it's called Obesity, Evaluation and Treatment Essentials. It was written, copyright in 2016, by two very important authors, Dr. Steelman and Dr. Westman, who are both past presidents of the largest organization in America to educate physicians how to do bariatric medicine properly. They're the past presidents who wrote the book. Right? So I'm going to read from this book just about the part about dosing. And it won't take long, I promise. Dose ranging, chapter 8. The 2008 ASBP stands for the American Society of Bariatric Physicians. That's what the organization was called back in 2008, but then it changed its name to what we now know as the OMA, the Obesity Medical Association. The 2008 ASBP Prescribing Practices Survey asked the question to members of the OMA: what are the lowest and highest doses you prescribe of phentermine? And although the average dose was 56 milligrams a day, a tablet of phentermine is, by the way, 37.5. That's what the manufacturer uses. But the average bariatrician used 56 milligrams a day on average. But significant numbers of physicians prescribe much more than the average high dose. 11% prescribe 60 milligrams. Almost 20% prescribe 75 milligrams. That's 2 tablets a day. 3% prescribed 90 milligrams a day. 4% prescribed 112 milligrams a day. 1% prescribed 150 milligrams, and another 1% prescribed 180 milligrams as the highest dose. My personal range is from 18.75 milligrams, which is a half a tablet, to 75 milligrams, which is 2 full tablets a day. The survey, these responses were that at least 50% of members of the OMA surveyed have titrated phentermine above the PDR recommended dose, including the 2 past presidents who wrote the book. This practice of dose to effect titration of phentermine is therefore very commonly practiced in bariatric medicine. In phentermine dose to effect, that is, dose it till you get the effect that you want. In phentermine dose to effect titration, the dose, perhaps set low initially to avoid undesirable stimulant effects, is adjusted upwards if the patient complains of hunger, if weight loss is less than expected, or if harmful eating habits worsen. Doses may be adjusted up or down at any time during the course of treatment, depending upon the patient's weight response, his or her perception of hunger, side effects, or changes in eating behaviors. Some patients may stay comfortably at their starting dose for years, whereas others may need higher doses soon after starting, and still others may benefit from an adjustment up or down after many months. Anytime a patient reaches a plateau in weight loss in spite of good compliance, dose adjustment upward should be considered. Anytime the clinician or the patient detects changes in eating behaviors, dose adjustments should be considered. Conversely, if side effects occur at any dose, dose reduction should be considered if side effects cannot be managed otherwise. Dose to effect titration is common practice in medicine and is used with a wide variety of pharmacological agents. Dose to effect titration of amphetamines is the standard of practice in the treating of ADHD. Higher doses higher than the limit suggested on the label for anorectic anti-obesity drugs have been discussed in presentations numerous times at the meetings of the ASBP and at the annual review course of the Board of Bariatric Physicians, that some patients benefit from doses of phentermine higher than the FDA label recommends. has been discussed numerous times in the peer-reviewed medical literature. And I listed not only the book, but I have several other articles I have for your convenience, if you so desire, of the popular articles that suggest increase in the dose of phentermine is highly effective and safe to do. The FDA also observes
I'm
that
sorry,
the-
Doctor, could you
I
tell me
need
how
to
much
keep going.
longer I'm gonna let you finish, but could you tell me how much longer your answer's gonna be? I thought it was gonna be a 3 minute.
Oh, maybe 2 minutes, okay? The FDA also observes that accepted medical practice includes drugs use that is not included in the approved labeling. Every PDR states the FDA stance on off-label drug use by physicians in the forward of the PDR as part of a physician's right to do so legally. The rules and regulations of Mississippi's licensure, Rule 1.5, use of diet medication, co-authored by me, was intended to update Mississippi's regulation to modern bariatric practices of today and out of the antiquated guidelines of the manufacturers back in 1959. Rule 1.5, use of diet medication, second paragraph states, prescribing or dispensing a controlled substance for weight reduction or the treatment of obesity should be based on scientific knowledge and sound clinical grounds. This alludes to the entire usage of the drug, usage, duration, and dosage. I've just stated the accepted scientific knowledge and sound clinical grounds from the country's largest organization for the education of doctors and providers in the field of bariatric medicine, the OMA. That phentermine can be used safely and effectively at higher doses for over 30 years. Nowhere in the rules and regulations governing bariatric medicine does it restrict the dosage or the duration for use of Schedule 3 and 4 anorectic drugs for obesity. That's all.
Nowhere did I hear you mention in any of that answer, other medications that the patient is taking. That's all about phentermine. What
Correct.
about
Well, that's
other
the question.
medications? What about other medications? You have to, Topamax.
Okay, so you want to know about Topamax
No,
now?
I certainly don't want another, lecture about Topamax, but that's another medication that's, it's an anti-seizure medication, but it's used off-label, for weight loss. Is that right? May be used off-label for weight
Well,
loss.
let me clarify that, okay? That's not exactly true.
Okay,
So Topamax was made in 1996 and it was FDA approved for epilepsy and seizure disorder. A year or two later, it was FDA approved for prevention of migraine headaches. But almost immediately upon usage of the drug, physicians of all specialties noticed that patients were losing weight on topiramate. They didn't know why at the time, but that was a common known side effect of topiramate was weight loss. Later in 2012, the FDA approved a drug called Qsymia, which is the combination of Topamax and phentermine. Now, if I want to use phentermine and Topamax together for weight loss, I use it in the form of Qsymia because it's FDA approved for that purpose. If I use Topamax alone, I use it for binge eating disorder. It is the gold standard for binge eating disorder. Okay. There's another drug that we could use. Some antidepressants are commonly used for that purpose, but I feel Topamax works much better than Prozac or Paxil. Vyvanse is the other drug that's FDA approved for the sole treatment of binge disorder, but that is a Schedule II drug. Okay. And I don't feel comfortable using a Schedule II drug for binge disorder. I feel much more comfortable and get equal results out of Topamax. That's how I use it.
if you prescribe Topamax, in combination with phentermine, instead of using, Qsymia, do you, use the same dosage of the two medications that?
No, sir, that's not what I said. That's what
No,
you said.
No,
Please let him finish the question before you answer for the court reporter. Thank you.
you do prescribe at times, or have in the past prescribed at times, phentermine and added Topamax, have you not?
For binge disorder.
Yes, sir.
Yes, sir.
When you do that, do you does the dosage of Topamax that you use, does it exceed the combination of phentermine and Topamax that's included in the medication, the name I can't pronounce?
Okay,
The combination, yeah,
so
yeah.
Qsymia comes in several different dose ranges. It typically starts off at 46 milligrams. The standard Topamax dose, if you're just using Topamax, would be 50 milligrams. All the way up to 96 milligrams of Qsymia, which is, basically 100 milligrams of topiramate. And I do not use it in excess of that, no.
Hey, doctor, when we're talking about, hormones, and you're talking about the, algorithm that BioT has available to physicians that you use for dosing.
Right.
Okay. Regardless of what that algorithm tells you, don't you agree with me that the ultimate decision as to dosage rests with the physician?
Yes, it's a suggestion. It's a recommended dose.
It's a tool that you can use.
It's a tool that I use.
Okay, let's take a look at that. Let's look at page 671, please. 671.
Yes.
Now, is this a graphical representation of this algorithm or how you use it?
Yes, sir.
Okay. Where is this software? Is it like on your system? Is it online?
Both.
Okay. So will this particular page, would this have been online or from your system, or can you tell?
I use it on my computer.
All right.
It's an app we use.
If you would look down, this was patient one. We're still all these records we've looked at so far, patient one. If you would look down at primary labs.
Primary labs.
See it?
Yes, sir.
Okay, and you're very familiar with this form, aren't you? Testosterone level 473.
Yes, sir.
Is that normal range?
It is in a normal range, but it's suboptimal.
Suboptimal. Do you have any estimate of how many people are walking around right now today with suboptimal testosterone levels?
Most.
All right, let's look at the thyroid labs. TSH 1.167. That's in the normal range, is it not?
For a TSH level, yes.
Okay. Total T4 level 5.2. That's in the normal range, or is that a little high?
Low normal. Low normal.
Low normal. Okay. Free T3 level 2.5. That's also in the normal range.
Yes, but it's suboptimal. Okay, suboptimal. The range goes from 2.2 to 4.2. So if you're under 2.2, a chimpanzee can figure out that you're hypothyroid. Okay. If you're on the high end of normal, that's where typically most young people live. Okay. Under 3.0, for me in my practice, is typically where all the symptoms occur for hypothyroidism. It's mild to moderate secondary hypothyroidism.
Okay, but you agree normal range.
It is
Suboptimal.
Suboptimal normal range. Correct.
Okay, look at the top of the page. This is where you get dosage recommendations from this algorithm, correct?
Yes, sir.
All right, testosterone. So despite testosterone 473, which you agree is a normal range, but suboptimal, it tells you to use 8 T200 pellets and 1 T100 pellet. So it says use 79 milligrams of testosterone, give it to this patient despite the fact that their testosterone level is in the normal range of 473.
Okay, let me clarify that. I see what you're kind of getting at. But you need to know something about testosterone. Okay? There was a pretty much landmark article that came out by the Mayo Clinic in 2016. It was called the Male and Female Consensus Committee Resolutions. It's an international panel of experts in the field of testosterone and hormone replacement therapy. This was in 2016. State clearly, now they will go through all the resolutions, but I'm not going to. But the primary one that you need to to clarify this, was that clinical manifestations of testosterone deficiency do not occur at a definitive threshold. Okay, so you may be 473, you can call it normal, but you may have lots of symptoms and suboptimal T levels.
Right, so I believe, am I right, am I understanding that you're saying that you have to look at the objective lab values, but you also have to take in the subjective information and complaints and something that you receive from the patient?
Yes, so if a male, for instance, had a testosterone of 350, which would be considered suboptimal, and he had absolutely no symptoms, you would not treat that male.
Let's go, if you don't mind. Let's go back to page 677. I will do several of these pages on blood pressures. 677, let me know when you get to it. I'm there. Okay, so the blood pressure on that day for patient one was 153/67, right?
Yes, sir.
And this looks like a PA, one of your PAs prescribed 30 tablets for a monthly supply.
Correct.
37.5 milligrams a day. Flip over to page 679. Okay. Blood pressure that day, 143/96.
I see 143/96.
Do you agree?
143/96.
Or is it 86? I can't, yeah, 143/96.
86. That's an 8.
Okay, at the bottom of the page, again, phentermine 30. And then there's, it looks like two different handwritings. There where it says medications added or changed, and there's apologies, but it looks like it has a sprawl. Is that not your signature?
Let's see, could you say it one more time?
Excuse me, is this your handwriting?
That's my QA signature. This fell into the 10% of patients that I had to do QA on.
Right. So you reviewed this chart and did you disagree with anything that was on it?
No, I agree with everything.
All right, flip over to page 681. Blood pressure on 9/14/15 is 130/84. That's pretty good.
It's a good blood pressure, yes.
130/84. It'll be slightly elevated. Continued 37.5 milligrams, 30 phentermine. Flip over to the next page, 682.
Yes,
Blood pressure on that day, 156/86, correct?
correct.
Phentermine was increased to 45, that is 1.5 pills a day.
Correct.
Would flip over then to page 684. Blood pressure 160/82, I believe,
Yes, sir.
and continued at 45. 1.5 pills of phentermine per day, 45 for a monthly supply.
Yes, sir.
Next page, blood pressure 165/85.
Yes, sir.
Phentermine's maintained at 45. Flip over to page 687. 167/83. Continued phentermine at 45.
Yes, sir.
Page 688, blood pressure 165/85. Again, continued phentermine 45. And I've noticed several references throughout this chart to this patient number one needed to decrease his alcohol intake because it was lots of calories in alcohol. Is that fair? And that was hindering his progress. He needed to reduce his alcohol consumption. Now, I wanted to, if you look at page 691, did you prescribe phentermine for your patients and send them to the pharmacy, or do you also dispense phentermine in your clinic?
There was a time in our clinic early on that we did dispense out of our clinic.
And I'm looking at page 691. Yeah, and that's what I wanted to ask you about it. And that's your signature as the dispensing physician on March 21st, 2016, correct?
Yes, sir.
Okay, do we turn to 706? On that day, patient one, blood pressure 163/82. Again, we agree that's uncontrolled hypertension, correct?
Yes, sir.
On that day, phentermine was increased to 60. Is that right?
To two full pills a day.
Right. A monthly supply was 60 pills.
Correct.
And you have offered the board a long explanation of your rationale for prescribing that is double the maximum recommended dose from the label, correct?
Correct.
All right, let's look at page 719. Let's shift gears. Let me know when you find some.
Yes, sir. I had it.
Okay, so, T4 levels 5.2. And the reference range, I'm assuming, am I correct that the 4.5 to 12, that's the reference range put in by the lab?
Yes, sir.
Okay, so 5.2 is within that normal reference range, is it not?
Low end of normal, yes.
Okay, TSH 1.167, that's within the normal range for TSH, is it not?
Right.
And isn't a low TSH a good thing? Isn't that what you're looking for?
I don't use TSH. Okay, there's a camp on either side. So there's a camp of physicians that diagnose and treat hypothyroidism using TSH and T4. And there's a whole another camp of physicians like myself who prefer to use the more accurate free T3 level to diagnose and treat.
Okay,
So
so
more than one way to skin a cat on hypothyroidism.
so do you just ignore the TSH or do you factor it in?
I think it's highly inaccurate. It's just a gross term that I don't typically use in my treatment of how I treat a patient or diagnose them. Unless if we're dealing with primary hypothyroidism, which is the brain secreting TSH, talking to the thyroid in the neck that secretes T4, if the thyroid is not listening and it's not producing T4, then the TSH continues to rise and scream at it louder to make more. That's primary hypothyroidism. And that's what you're going to find a lot with elevated TSH levels in hypothyroidism of primary. But you won't pick up secondary hypothyroidism in that fashion, which is T4 is simply inactive thyroid hormone. It doesn't do anything in the body. It must go to the liver to then be made into T3. The T3 is the active hormone that does all the work in the body, and that's the one I prefer to use because it's much more accurate.
In T3,
But the TSH will not be elevated in that case.
okay. So the T3, once it's processed, once T4 is processed by the liver and converted to T3, that goes throughout the body and it's used by all tissues that need the T3, correct?
Correct.
Brain, central nervous system, heart,
Particularly the heart.
like
Like the heart will only typically use T3.
all right, well, on page 719, the free T3 result 2.5, the reference range is 2.0 to 4.4. So that's within the normal reference range. I'm assuming you're gonna say, but that's low normal.
It is quite low.
Okay. But
And the patient had significant symptoms along with the low level.
okay. And on that day, testosterone, a little bit below that, 473. reference range is given of 300 to 720 by the lab. Is that right? Yeah, handwritten in is 900 to 1100. Is that your handwriting or is that something else?
That is my handwriting.
Okay, and so you're saying that your reference range for that is 900 to 1100, is that right?
Yes, sir.
And is that your target range? What exactly is that?
I would,
900?
yes, I would love to target them at 900 to 1100.
Well, I'm saying, but you're not saying 900 is the low.
That 900 is low.
Well, it says 300 to 720. I'm assuming that's low normal is 300, 720 high normal according to the lab. So what I mean, your 900 dash 1100, what exactly does that mean? That's what I'm trying to ask.
All right.
Sorry.
This particular reference range from this particular lab was 300 to 720. But when I'm pelleting a male or giving him testosterone injections, I'm trying to get the peak level at between 900 and 1100. This lab has since changed their number that I used to 1100.
900 to 1100, is that not above normal testosterone levels?
No, I stated a little while ago that normal ranges falls between 280 and 1100.
For a 64-year-old male like
Yes.
one,
Yes,
1100 is normal range
the
for a
normal range
64-year-old
is from
male.
280 to 1100 with all males.
That doesn't change with age.
It does change with age, but the normal value on the lab report will say 280 to 1100. There's lots of males that walk into my office who are 60 years old that still have 800 testosterone levels and don't need any treatment.
Right? So look on page 725, please. And the page before that, 724, I believe. Those are the labels from the testosterone pellets that you use for this patient. Is that right? You for those like peel off, do they go into the record?
Yes,
Okay. The next page shows blood pressure of 142 or 84 on that day, correct?
yes,
Okay. And you inserted, was it 1,700 milligrams of testosterone in pellets in this patient?
I did.
Turn to page 728. T4, you told us that you do not consider that value, but 5.5 resolves is within the normal range here by the lab, correct?
Correct.
TSH 1.2, that's within the normal range of 0.3 to 4.2, is it not?
Yes.
Free T3, 3.5, that's in the normal range of 2 to 4.4, correct?
Yes. You'll notice it's much higher than 2.5 because he was on treatment already.
All right. And that was Nature Thyroid. That's what you
At the
put in,
time
right?
we used, that was a brand.
Okay, Nature Thyroid, who produced that?
I don't know who produced it, but it's similar to Armor Thyroid or NP Thyroid. It's a combination drug of T4 and T3 together. It's desiccated.
Does BioT make a product containing T3 and T4?
Not that I know of.
Okay, well, let's look at the free T3. Well, we look at that. Look at the testosterone,
Yes, sir.
1437.
Yes.
Okay, so that's post pellet insertion. This is 127 of 17, and it looks and the pellet insertion was December of 2016. Is that right? 12/22/16.
No, you'd have to tell me what page.
725. That's one of the pages got the date.
Okay, I have it. That was his first insertion, yes.
Okay, so when he came back, month follow-up, his testosterone was twice the reference range, almost twice the reference range given by the lab, and in excess of the range that you just mentioned of 900 to 11, correct?
Correct.
Okay.
But the reference range I use typically is 900 to 1100 is where I want the male patient at. So it was a little bit higher.
Next page on 729, T4 5.5, that's in the normal range. TSH 1.260, that's in the normal range, correct? Oh, I think this is just that's a duplicate, I apologize. Page 731. Blood pressure 166/99, and the patient is getting a monthly supply of 60 Phentermine, that is twice a day, correct?
Correct.
Page 732.
Can I-
Yes, sir.
Okay, you'll notice though, on that particular blood pressure of that day, you see what his pulse is?
Mhm.
It's 107. So this is a very atypical blood pressure for this patient. A pulse of 107 is not his normal. So it's highly likely that the patient was either anxious, came in late, waiting for me, and his pulse rate went high, artificially elevating his blood pressure.
Well, the one
That is not a typical blood pressure count.
I agree that 99 certainly doesn't appear to be typical, but the 166 is not particularly out of the norm, is it?
It depends what time period you caught the patient at. So if you caught the patient when he first came to me and he was morbidly obese at 319 pounds, his blood pressure was much higher. But after he lost 96 pounds with me, his blood pressure was nearly normal. You see how odd that blood pressure is compared to the ones after and before it. Because it's not typical.
Would you turn to page 745, please?
745.
Yes, sir. And you there? I'm sorry.
I'm there.
Okay, this is, again, this is like a follow-up, second round dosing. This is from that algorithm recommending program, correct? Okay, dosage recommending. And this shows that 1437 testosterone value, correct?
Correct.
All right. So there's a slight reduction in the amount of testosterone pellets that you inserted on that second round. Is that right?
No, that's not a slight reduction. That's a significant reduction going from 1,700 to 1,300 milligrams. And that's because its testosterone level was 1,400, so we lowered the dose.
Page 758, please. That was third pellet insertion for this patient, correct?
Yes, sir.
Okay. So it looks like this is dated October 17, so it looks like you kept him at 1,300 milligrams from the previous pellet insertion. Page 775, sir. Blood pressure 171/93, pulse 91. So in both elevated, even
That's
above his normal range.
Yeah, but you're not looking at the whole picture yet. If you notice at the top of the page, we did a blood pressure a second time because it was elevated. We wanted to see if it was real. You see where it says number 2, 144/78.
Right? you kept him on 60, or you prescribed for him, or your PA prescribed for him, 60, Phentermine.
Correct.
And that's your signature and chart check this, signed off.
That's my QA signature.
So. I believe we discussed this, Phentermine is a stimulant medication. You agree with that?
I do. It's a mild stimulant.
Does testosterone, can it have an effect on the heart?
No, there's no CV events with testosterone whatsoever. That's been disproved long ago.
All right. What about, thyroid replacement? Thyroid supplements? Can those, affect the heart?
Well, if the patient has hyperthyroidism, that could potentially increase the pulse rate of the patient.
Well, if you increase the free T3 in the system, that's gonna affect the heart of the soul, is it not?
Paul, give me 1 second. I'm sorry. I apologize. We're going to actually take a break at 10:30, so you may continue at this time.
So in your opinion, doctor, combination of medications that, and these aren't the only medications this patient on, right?
No.
But Phentermine, thyroid medication, testosterone, those three medications acting in combination. Did you consider the combined effect that those medications might have in your treatment of this patient?
You said testosterone, thyroid, and Phentermine.
Yes,
Did I consider it in combination for what purpose?
the treatment of this patient.
Yes.
Okay, and so it's your opinion that that dosage and the use of those medications concomitantly was safe and reasonable.
Yes.
Doctor, is insomnia a common side effect of taking Phentermine?
I wouldn't say it's common. Probably about 10% of patients, maybe 20 at the highest, will have some iatrogenic insomnia from Phentermine.
Iatrogenic, that means therapy
I'm sorry.
induced or medic.
Through the medication alone cause the insomnia.
So the stimulant medication causes insomnia. So I believe, is it your practice to give either Ambien or Restoril? Generally one of those two medications to counter that?
You know, back when you took these charts, which were 2011, my practice of using sleep aids was different than I presently use. It's kind of evolved. And that's just from my surgical background. I was trained to use Ambien and Restoril as primary go-tos for sleep for my hospitalized patients. And I've never had a problem with those drugs in 25 years. And I continue that in my bariatric medicine practice, but I've evolved kind of. I don't really do that as my primary drug of choice anymore. I will either do, it depends on what kind of sleep problem they have. If they have a problem going to sleep, that's common to be associated with Phentermine. Sometimes you just have to use a light dose of Pendolol. This type of sleep problem almost always resolves on its own. Pendolol or maybe a light dose of Trazodone. If it's this type of sleep where you can fall asleep, but you then wake up in the middle of the night and can't go back to sleep, that's a little bit more troublesome. But I still treat these patients starting with either over-the-counter drugs like melatonin. I'll then, that doesn't work, I'll go into non-scheduled drugs like trazodone or Remeron. And really, I reserve Ambien or Restoril or Nesta for very stubborn insomnia.
Is phentermine still your first line medication for weight loss?
If there's no reason not to use it, I love to use the drug initially.
What about, the newer classes of medications, the semaglutides, Wegovy and Mounjaro? I realize that they're different chemicals, but obviously you're familiar with those medications.
Yes, sir.
Okay, do you use those in your weight loss practice?
Rarely. The problem with those drugs is I would love to use them more. I think they're wonderful drugs. I would like to get out the dark ages of using drugs that are 60 years old. But unfortunately, in Mississippi, that's not possible. The overwhelming majority of the population does not have access or insurance coverage or the out-of-pocket expense for tirzepatide, which is Mounjaro, which is $1,500 a month, or semaglutide, which is Wegovy, which is $1,300 a month. I just can't get it for my patients.
And there's a supply problem internationally.
There is. There is.
Are those, do you plan to move toward those medications if they become available? And if the
Objective border relevancy. He's being charged with past conduct, not what he plans to do in the future.
are those medications, I'll withdraw that.
Okay.
Are these new medications safer medications than phentermine with fewer side effects?
I wouldn't say that. I wouldn't say that. They're more effective. More effective. More effective.
If you would, Doctor, now, if you turn to page 839, this is patient 2 in the affidavit, initials LS.
I'm sorry, Mr. Ford, you said
3.
830?
See what, let me back up. Let's start on 826. 826.
We're starting another patient. Can I suggest this might be a good time?
Yes, please.
Absolutely. Let's take a 10-minute break, please. back on the record at 10:43. Let me make sure. Attorney Mercy, are you ready to proceed back there?
Yes, I'm sorry.
Yeah, no, you're fine.
Have a nice-
Okay, got it. Hey, Mr. Barnes, we're ready to meet for.
Believe I left my notes in my office, but
Okay.
I'm gonna go forward. Doctor, if I may proceed, Dr. Sutter, I believe we were talking about, page 826, is that right? Is that the page you're at? Okay, and this is patient two, initials LS, patient two in the affidavit. And we're looking at, sorry,
LM?
LS.
LS.
LS, yes, sir, yes, sir. I agree, it's very confusing, reviewing the charts, and I apologize. Again, as we look here at testosterone value, it's 22, which is low. Is that right? It's low. It's marked as low, but that reference range, beside it, that's a male reference range, isn't it?
It is.
Okay,
It's an error.
it's an error by the lab.
Correct.
All right, so what is the female, normal range for testosterone? That you,
Well, the laboratory reference range is 6 to 82.
what's the range that you consider for that? Or best, I mean, what range do you use, doctor? I'm not trying to ask an unfair question.
Well, obviously the lab made an error here. They thought this person was a male, so they gave me a male reference range, even though they're female. And the typical female reference range is 6 to 82. So even despite the range being off because it's a male range, the absolute number that you see is correct. It's 22 nanograms per deciliter, and that's low for a female.
Okay. Page 830. I want to ask you about this. The values I see reported here are T4, 6.4, that's normal range, and TSH, again, a 1.975 normal range. I don't see a free T3, that a free T3 was done on that patient that day. And if you see it in any of the surrounding pages,
Well,
go ahead. Do you know why a T3 wouldn't have been, T3 test wouldn't have been taken? And I think the only reason I ask is because you took, said that T3, free T3 was really the test that you, relied on.
well, it's a little difficult to find it in the way this chart is because the weight loss chart is intermixed with the hormone chart. So it's a little bit hard to find, but I do have what her T3 was originally.
Okay, and is that, can you direct us to a date or if not a page?
Well, I have it on my base number that I'm using. Is that okay? I'm not sure it corresponds to yours.
So, well, could you give me the date that the lab was saying?
I don't know the date.
Well, where did you get the value from? There's
From
no
the
date
chart.
on the page.
From the chart.
I see the page. Right, too.
Well, I'm going by the base number.
If I
We can move on.
I'm sorry, did you have a comment?
yes, to assist the board and the witness, he has the actual charts there. If he could be allowed to refer to those, if that would assist in presenting the information to the board. The original charts.
In response
This
to-
issue has been covered and covered and covered. And I know that, we're making a record here. And I would like to make the record that this has been covered and ruled on, and I will move on and withdraw the question. All right. Doctor, would you turn to page 857? 857. I'm sorry, 854. I apologize. 854. 854. This is the initial, pellet insertion on patient LS, correct? Um, there's no free T3 value.
I didn't write it down, but I know the values.
Well, go ahead and just tell us, what was the value?
I'm gonna take it directly from the chart.
Just please tell us
So
the
the
value, sir.
Free T3 level initially was 3.2. And the follow-up on it was 2.9.
Those are in the normal range, are they not?
They're on the lower end of normal, yes.
All right. So first pellet insertion was in December of 16, correct? And that's shown on.
December of 16. Yes, sir.
All right, so, would turn to page 861.
861.
Yes, sir. Received by the lab, date in upper right-hand corner, 1/24/17. So, am I correct? I'm sorry, did you find the page? Am I correct that these are follow-up labs, basically a month after the
Yes.
first pellet
6
insertion?
weeks later.
6 weeks later. Okay, at the bottom of the page, testosterone high 156. Is that correct?
Yes, sir.
And a reference range is given as 9 to 55. That's the lab's reference range for normal, correct? 9 to 55.
Well, yes, sir, but you have to know that this is a 6-week testosterone level after a hormone pellet was already placed. So it's a procedure. You don't swallow it. It's a little procedure that goes inside the body. So it can't be diverted. It's inside the body. And the 6-week T level that we're looking for it to peak at is between 150 and 250. And this falls within the range that I wanted it.
Why are we looking for a peak of 150 to 250 when a normal range is 9 to 55?
Well, because that's not the range we use when we're talking about a peak level. Remember, we're trying to increase their testosterone level to where they were, and those symptoms will resolve at a particular way they feel. And usually BioT's numbers are between 150 and 250 for a female.
So we need to basically triple the high reference value for normal testosterone to get to BioT's target range.
And that is because if you peak, remember, at about 8 weeks, the testosterone level is going to fall to about 100 to 200. And then by 16 weeks, it's going to fall down to 50 to 80 typically.
Excuse me, doctor, I thought earlier.
So we need to peak up a little bit higher.
Okay, I'm sorry. I thought that earlier, doctor, you said that pellets were preferable because they were much more even and you didn't have the peaks and the valleys.
Well, remember, this is over a 4-month period of time. So it's much more level compared to an injection where it's going up and down by the week or by the month.
Page 866. This patient, LS received, prescription, I think Julie Barmer, is that one of your PAs?
It is a PA, yes.
She's getting Nature thyroid 97.5 milligrams.
Correct.
Page 867. This is on, appears to be 3/2/2017, so approximately 4 months after the insertion of the pellet. 6-week testosterone level 156 post pellet. And this is for a reinsertion, correct? That's the second visit. Okay, so you lowered the dosage, am I right? Or did you not?
If you could show me the first pellet, what the dosage was on.
All right. Yes, on page 854, the first dosage was 125. So you maintained it at 125.
Yes.
Okay, so you were comfortable with the 6-week testosterone level of 156.
Yes, she had complete resolution of her symptoms.
Doctor, please turn to 904. Doctor, is resolution of the symptoms, is that the only concern that you have regarding the dosage of patients in weight loss and hormone therapy?
Could you rephrase the question, please?
I'll rephrase. Is your aim in hormone replacement therapy simply to get to the spot where your patient feels good?
The range of testosterone that we typically shoot for is between 150 and 250 nanograms per deciliter. And usually at that range, these symptoms will resolve.
So if the patient says, I feel good at 250, I want to stay at 250, even though it's on the high, high end of the reference range. Is that the determining factor on your dosage?
Well, if her testosterone level correspondingly is not too high, it's at 250, I'd be more than happy to keep her at 250 if she feels good at that range. And she wouldn't have any adverse side effects.
All right, page 904, looking at thyroid testing, T3, pre-T3, 6.4. That's a high value, is it not?
Okay, so it is a high value, but you have to understand something. This thyroid level was taken at 10:19 in the morning. It is falsely elevated because of the time that the patient took the thyroid medicine. If you take it within 5 hours, it's going to give you a falsely elevated level. So it was repeated.
All right, and when was it repeated?
On the follow-up lab, if you could show me the follow-up labs on it, that might show it.
I will, we're moving toward that as we go on page 906. Total testosterone, 67. The reference range there is given the 6 to 82. That's normal reference range, correct?
Okay, this is most likely the testosterone level when she was at the bottom, where she's at the trough, getting ready to be repelleted typically.
Page 910. This is a reinsertion visit, correct?
Correct.
Testosterone dosage is 137.5, so that is an increase from the 125 milligrams previously, correct?
Correct.
Above it in your notes, I tell you what, just read me your note there about 45-year-old white female for 6 pellet. I'm not sure I can read it.
Okay, would you like me to?
Yes, sir.
Okay, so it's a 46-year-old white female with a 6 pellet, had problems with the last pellet, which became infected but never expelled. Boost was placed, which did help with her symptoms. Needs a higher dose, now in menopause, FSH of 75, no period times 4 months.
Okay, if you would, look in the bottom right portion of that, form where you're talking about the T3 level. Could you read that, please?
Says T3 level 6.4, but took thyroid medicines 2 hours prior to the lab. Draw giving a falsely elevated level. Will withdraw.
Turn to page 924, please.
924.
Yes, sir, page 924, the date, print date is 4/30/18.
Yes.
I believe the previous, day we were talking about was 4/26/18.
Yes,
Okay, so is this a follow-up lab?
it was.
Okay, so the free T3, 3.4. So it's in the normal range,
Correct.
okay? Um, Doctor, let's talk about patient number 3.
I'll do that. You should say page number 3.
Patient number 3. And you'll find, our chart starts on page 1031, 1031. This is a female with the initials of LM. I'm sorry, 1031. What are some of the possible, strike that, what are some of the common side effects of testosterone therapy in women?
I've only seen 2 side effects typically in the last 7 years that I've been doing them. You can get hirsutism, which is facial hair, or you can get acne. I've never seen any other side effect with it.
And so, how do you treat those things?
Well, if sometimes you can lower the dose of the testosterone, but if they like the way they feel on the particular dose and they don't want to decrease it, then you can use spironolactone, which is a potassium-sparing diuretic that will clear up acne fairly quickly, and facial hair. Decreases the growth of the facial hair.
I want to ask you this about page 1065, 1065, because I'm not sure I understand, your, this and that, and it appears to be in your handwriting.
1065.
Yes, sir, 1065. Down toward the bottom, it appears to say you missed 1/2 pill again too many times. Is that correct?
She had a problem with remembering to take her half pill.
Okay. So at that time, she was getting 45, a monthly supply for this patient was 45, 1 in the morning, half tab in the afternoon. Correct?
Correct.
The next page, 1066. Again, that's your signature at the bottom.
1066.
Yes, sir, it's the very next page. That's your signature at the bottom of this page, isn't it?
Yes.
Medication, phentermine dosage is increased to 60. That is twice a day, correct?
Correct.
What is Trokendi XR, doctor?
That's an extended release Topamax.
So do you add Topamax or Trokendi medication like that if Phentermine is not producing the desired, results?
Now, I typically use Topamax for binge eating disorder.
I apologize. You have said that before. I apologize, doctor. Doctor, briefly, I'd like to talk to you about patient 5. Patient 5, and this is the patient is a male with the initials of TF. TF,
You have the number on it?
I do. Starts on page 1289, sorry, 1289.
Yes.
On page 1295. And
Yes.
these look to me, I want to make sure, these are intake forms as opposed to follow-up visits, is that right?
1295 is an original history and physical and initial visit.
Okay, so, right, initial visit. BP that day was 143/84, correct?
I'm sorry.
143/84 blood pressure.
Yes.
And this is a slightly, well, this is initial intake form, that's why I was trying to get to that. On page 1297, the patient, reported high blood pressure, using CPAP. I'm assuming that's for obstructive sleep apnea. Is that correct?
Correct.
Gives a family history at the bottom of heart disease, correct? Correct. This patient, again, without the demo, this is the physician. Is that correct? The patient TF, this patient is a physician.
Yes.
So on page 1304. A follow-up visit on 2/28/11. Blood pressure 164/81. I think we established earlier that's not controlled blood pressure, is that right? Controlled hypertension, excuse me.
It's considered by definition uncontrolled. But you have to remember, the patient doesn't have any symptoms, okay? Of high blood pressure.
The silent killer.
It can be called that.
I mean, I've heard it.
Not having a crisis in the world, like 164/81.
Right.
Doesn't have any chest pain. He's not complaining of shortness of breath. He doesn't have any symptoms.
And right next, yes, sir. And right next to that, I see 161/78. It looks like perhaps blood pressure was retaken.
It was.
Okay, but again, a very similar, slightly lower result.
Correct.
Okay, bottom of the page that day, it looks like, I can't tell if this, some of it looks like your handwriting, some of it doesn't. But Phentermine 30, it was prescribed in monthly dose 30, so 1 pill per
Are
day.
you talking about page 1304?
Yes, sir.
My handwriting is not on this page.
Okay, I was just referring to that. It looked like a slightly different hand.
No, that's the PA's
Okay, and I apologize. Thanks for clarifying that for me. On 1305, the very next page, blood pressure 160/84,
Yes,
retaken 144/75.
that's common for the blood pressure to drop after they get into the room and start talking with them.
Dosage increased to 45 per monthly spot, so that's 1.5 pills a day.
Right.
Flip over to the next page, 1306. Blood pressure 132/84. Again, it's pretty good, correct?
Yes, sir.
And continued at 45, or the PA did. The next visit, looks like this 2 months later. On page 1307, blood pressure 152/85. The pulse of 74, so that doesn't look like the patient was, that's like an artificially elevated value.
No, I believe the blood pressure.
Okay, maintained 45 dosage. Page 1308. Blood pressure 168/88.
Yes, this is highly uncommon for him, and in the column next to it. As this patient was in an emergency room position, so he did the night shift. And so he frequently forgot to take his medicine before coming to me. So in the column there, it says just took blood pressure medicine.
I see
It's
that.
not his typical blood pressure.
Okay, there in the middle of the page, of course, side effects from taking the med, insomnia. And it appears that Ambien was prescribed to deal with the insomnia. Is that a correct
The
reading?
patient came in to me with insomnia. Patient was already on Ambien before they even did that thing.
You continued it?
I did.
Okay. On page 1312. Blood pressure 141/66. Very good low number, correct? Correct. Nice on. Drop, the phentermine should drop to 30. Then on the next page, page 1313. Blood pressure is 168/86. Pulse 73. Doses increased to 45. That is 1.5 pills a day. Correct?
Correct.
Look at page 1315. And that is your signature divider page, is it? Is that a chart review, or is this, did you see this?
No, that's me seeing the patient.
Okay, phentermine dosage increased to 60 a month, twice a day, correct?
It gained weight. That's why we increased it.
And when I ask you, upper right-hand corner, blood pressure, 126/71, pulse 62.
Right.
That's a highly unusual pulse value for this
No,
patient,
It's
is it
not
not?
for men on beta blockers, it's not.
Well, that's what I was gonna say. But it's out of line with the other pulses that are recorded. So at some point, you didn't put him on beta blocker, but at some point, someone put him on medication, you believe?
He already came in with 3 medications for his blood pressure.
What 3 medications?
If you go tell me where the history and physical form is, I can tell
We-
you the blood pressure medicine.
I don't think it's worth the time, to spend on it. This is in the record. These are in the record. But I was just looking back. I mean, I see a lot of pulses in the 70s, but 62 seems low. So can't tell if there was a change in that minute. The next page, 1316, pulse of 59, blood pressure 162/89.
Yes.
Okay, the pulse of 59. Maintain the dosage the PA did at 60, correct? Correct. Page 1318. blood pressure 164/85. Pulse 7.2. The phentermine dosage was 60 or 2 pills per day. Can you read the note there in the top right? Can you interpret that? Is there another part of it appears to be cut? But I don't see a new reading for blood pressure. Do you?
No.
Page 1320, please. Hormone lab value T4 6.7, which is in normal range, correct? Correct. TSH 0.955, which is in the normal range, correct?
Correct.
Testosterone 224 nanograms per deciliter, which is in the normal reference range, as indicated by the form of 200 to 700, correct?
Is in the normal reference range, is extremely low though.
On page 1323. Blood pressure 154/83. Pulse 63. Phentermine's continued at 60 per month, twice a day, correct?
Correct.
Page 1324. This appears to be one of your personal notes. Is that right?
Yes.
Blood pressure 151/82. Side effects since taking meds this month: insomnia and headaches. Maintained the phentermine at 60 per month. I don't see any other medication changes that on that page. All right. Page 1328. BP 160/87. This appears to be, again, a PA note. Topamax ? Why would be added Topamax? You say it's for binge, basically for binge eating. So that must have been an issue.
She was questioning whether she should start it or not.
Okay.
Wasn't sure.
All right. The next page, 1329, says didn't take Topamax.
Right.
Uh, 1350, please, or page 1350.
Yes.
And the assessment, again, this is your handwriting, I believe.
It is.
It appears to say has increased or aldosterone causing hypertension. Is that correct?
His doctor told him that,
Okay.
and he relayed that to me.
All right. You continued phentermine at 60 per month.
Correct.
All right. Page 1356. BHRT checklist for men. What does that stand for, Doc? Excuse me, Doc, I did not think. You, Doctor.
Bioidentical hormone replacement therapy.
Okay, now,
Checklist from that.
I apologize for speaking over you. So on that checklist, most of the items are marked never. 2 are marked mild, sleep problems, and weight gain, correct?
Yes. There's many times that a patient will put never, and once you question them in person, they then start to admit that they actually do have symptoms. which he did to me.
Doctor, if you turn to page 1437, please.
Yes.
Um, 10/2/2020, needs a call from you ASAP. Said it didn't require an appointment, but that it's quote urgent, close quotes, underlined, and says it regards Pellet calling about wife's treatment. So did you see that note?
I did.
Okay. Back up a couple of pages to 1428. Heading male initial pellet insertion form. We're on the same page?
1428, you said.
Yes, sir. Blood pressure, 177/105, pulse 72. Middle of the page, testosterone, 397, 4 days after an injection. And he was injecting 0.5 ml every week, is that right?
Right.
Okay. That's about halfway through the week, a little over halfway through the week, right? You're giving yourself one every 7 days, 4 days through.
He's a little bit past halfway.
Okay. TSH 1.2, free T3 5.0, total T4 7.8. And then you inserted 1,600 milligrams of testosterone pellets, correct?
Right.
Page 1435. This patient was already getting, he was getting, we talked about injections of testosterone. Middle of the page, there a note says, said he continued testosterone shots for 3 more weeks after insertion. Recheck, and so recheck total T and ED and 4. He shouldn't have done that, should he? Continue
Shouldn't have
the
done that.
injections.
He shouldn't have done that.
Right. And so you were gonna need to
Supposedly elevated his testosterone level.
and you were gonna need to repeat the labs. Is that fair? I mean,
I told him to stop taking the testosterone by injection. I told him that at the original pellet, but I guess that wasn't communicated effectively, or he didn't hear it, or he just continued to do it, whatever. But is what artificially elevated testosterone level.
okay, on 1436, yeah, the testosterone level at that was 1437. And you agree that that's high even for the 900 to 11 target range you previously described. Is that correct?
It's high because he injected testosterone at the same time as that pellet.
Sir, in your opinion, was patient 5's hypertension controlled or uncontrolled?
Well, That's a great question, because at times he had completely normal blood pressures, and at other times he didn't have so good a blood pressure. It was uncontrolled. He never became symptomatic when he had uncontrolled hypertension.
Even if he didn't become symptomatic on his business with uncontrolled hypertension, nevertheless, giving a patient a stimulant medication carries a risk, does it not?
It doesn't cause that risk, though. That is not a risk.
Increases metabolism, stimulates metabolism.
It's counterintuitive, right? So you would think that, and many physicians do believe that, because they think phentermine is actually an amphetamine, where it is absolutely not an amphetamine. And through the 64 years of doing phentermine, we now know it does not increase blood pressure. It does not increase blood pressure. In some studies, as in ever. Other studies I've read say it's 1 in 5,000. It will increase the blood pressure by 5 systolic or 5 diastolic points. In my own practice, I would say probably less than 1% of my patients have a direct effect of phentermine on their blood pressure by 5 points. There's many articles to back that up. All right, and I can introduce. And also mention that in no way is uncontrolled hypertension a problem with the rules and regulations of this board.
Is it not a relative?
It's a relative contraindication, not an absolute,
Right.
and which means relative means use caution when using it. And if the physician, the licensee, determines that the benefits outweigh the risk, the small risk that the phentermine may increase the blood pressure versus the benefit of losing weight, which will bring their blood pressure down, that's what I chose to do. It's a relative contraindication, not an absolute.
Yes, sir. And I was gonna say, it's not an absolute contraindication. Under the rules, it is an absolute contraindication under the labeling from the FDA.
I object, that's a mischaracterization of what the labeling says.
Overruled. He can answer. I'm sorry, did you have something further you wanted to say?
Yes, I think I'll get to it later, but that's a mischaracterization, and that is not what it says. It has a recommendation. It's not a contraindication.
And he's testifying, he can testify to what the label says. Again, your objection has been overruled. Continue.
The manufacturer's guideline is a suggestion, okay? I go by the rules and regulations of Mississippi to guide my treatment, whether I'm doing it in the correct form of scope of practice.
And so you do not pay attention to the label
I do.
information for the manufacturer.
Of course I do. So I factor in several things. I look at the manufacturer's guidelines. I look at what my Obesity Medical Association has taught me. I look at scientific articles and sound clinical grounds, and I make a decision whether it's safe to use the phentermine in this particular patient versus a small risk of increasing blood pressure.
And the label information that goes into a package insert and that the FDA approves, that has to be approved before the medication is deemed safe to go on the market, correct?
Well, back in 1959, they actually didn't test for that. But it was just speculation that it would increase blood pressure based on the fact that it was similar to an amphetamine. It's been disproven.
I don't think you answered my question. So my question was that the labeling and package insert have to be approved by the FDA before a product can be placed on the market, correct? In this particular case, for the purpose of weight loss, yes. And from time to time, labels are modified at the direction of the FDA, are they not? I'm not sure how they're modified. And if it's FDA or the company goes back and does further testing on it, I'm not sure how that's done. but you understand that there is a process by which the label, changes on occasion.
I'm not sure about this particular one, I have to change to.
Do you know whether, the labeling for phentermine, still provides that, uncontrolled hypertension is a contraindication for the use of phentermine?
It is considered a contraindication, it's a suggestion. But that was made in 1959. So 64 years of scientific evidence prove otherwise. So it has never been shown to increase blood pressure. The guidelines are antiquated. So that's why we changed the guidelines in 2012 to read relative contraindication.
So the company, with all of that evidence available to it, saw no reason to go to the FDA and ask to have the label changed to
That would
reflect all
never
that new
happen.
research.
Objection, argumentative.
I withdraw. I'll draw that question.
And for the record, I was actually going to sustain your objection.
Dr. Sir, thank you for your time.
Thank you, sir.
Respondent will reserve questions for this witness until the case is sheet and respond.
Understood. At this time, you may step down, Dr. Summers.
Thank you, sir, for your questions.
He did. Yes. Before you, Paul, give me 1 second before you begin.
I'm sorry.
I don't know who you say. Paul, they're going to check on lunch. It's supposed to be delivered at 11:30. I'm not sure who your next witness is and how long. I'm sure they'll take more than an hour.
At this time, I plan for my final witness to be Dr. Chance. Dr. Chance, you're muted. Could you unmute, and let us know? Can you come back after lunch?
Sure, what time?
Ms. Francis was going to check the.
We don't know.
We have no idea, so that's why I said
So
I don't know.
we should start with Dr. Chance.
It's here, it's not out. That's what I
Oh,
was
okay,
thinking in my
it's
head.
not, okay,
and
okay.
for-
We can do preliminaries.
Let's do that.
All right, stay there, Dr. Chance, and stay unmuted, please, sir. Flight Council calls, Dr. Ricky Chance. Dr. Chance, I believe you took the oath with the other witnesses at the beginning of the hearing, is that correct?
Correct.
You understand that could you speak up just a hair?
Okay,
All right, and you understand you're still under oath?
I do.
All right, Dr. Chance, if you don't mind, would you give the board, the benefit of your training education as a physician?
Right, well, I went to undergrad at Ole Miss, got a degree in pharmacy. Went back to medical school in West Virginia, got the degree there, came back to UMMC for my family medicine residency. Currently, I work with Memorial Health System, Memorial Hospital. I'm department chair of outpatient primary care. I'm associate program director of the family medicine program, and I practice full time.
You're board certified in family medicine?
Yes,
Dr. Chance, you are a family physician. You are not a weight loss or bariatric specialist, are you?
that's correct.
So your perspective on medical issues may be different from that of bariatric specialists. Do you agree?
Yes,
in your family practice, do you see patients with conditions such as hypertension, obesity, depression, low hormone levels, low T, thyroid problems? Do you see patients with those sorts of problems?
Yes, all of those conditions.
And as a family physician, you're not focused specifically on the weight loss or hormone therapy of the patient. You have to take a more holistic approach to the treatment of the patient, do you not?
Yes.
I tender Dr. Chance as an expert in family medicine and general medicine.
Any objection?
Object, and I'd like the board Dyer to witness. Good afternoon, Dr. Chance, or good morning still.
Yes.
Dr. Chance, you just testified that in your practice, you see patients with obesity, thyroid problems, and I think you said low testosterone. Did I hear that?
That's correct.
Do you have any specialized education in treating obesity?
No, I don't.
Do you have any specialized training in treating thyroid problems?
Other than what's the training required in family medicine residency and then the internal medicine component of my training, no other special qualifications.
Yes, sir. The question I'm asking you are in addition to your education as a medical doctor and your board certification as a family medicine doctor.
Yeah, no outside specialty.
Same question with regard to treatment of patients with low testosterone. Do you have any additional training other than what you received in medical school for treating low testosterone patients?
No.
In treating your patients with low testosterone, how do you treat those patients?
It depends on whether they're symptomatic or not. I err on the side of not treating them unless it's absolutely requested by the patient. They have symptoms consistent with hypogonadism, but I usually work them up for other causes of low testosterone if their serum levels are below the reference ranges.
When you treat a patient for low testosterone, what method do you use or how do you treat them?
Treat them with topical preparations, usually gel form and injectable IM.
You've never used the pelleting procedures that Dr. Sudduth uses, have you?
I have not.
You're unfamiliar with those procedures, aren't you?
Yes.
How many testosterone patients do you have in your practice? Low testosterone.
I don't know. I don't have that information.
Do you know what percentage it would be? Roughly?
Very, very low percentage.
With regard to your obesity patients, what percentage of your practice patients do you think are obesity patients that you're treating?
Treating for comorbidities or treating for obesity, please.
Oh, I'm sorry, I didn't mean, go ahead, I'm sorry.
Yeah, can you clarify? Are
Yes.
you saying patients that I treat for obesity or their comorbidities who they have obesity?
Patients that you're treating for weight loss who are obese.
I don't treat for weight loss.
For the patients you treat for obesity, what methods do you use to treat them?
Well, I just commented, I don't do weight loss medicine. With diabetic obese patients, if they qualify for a GLP-1 agonist with the secondary benefit of weight loss, I'll treat their diabetes, but I don't directly treat obesity with medications.
So I guess the same would be true that you don't treat weight loss with medications either.
That's what I meant.
So in your,
Other than the secondary benefits that one as a diabetic might have with weight loss utilizing a GLP-1 agonist.
so you'd agree with me that your experience and training for weight loss and obesity would have been from medical school?
Or residency, correct?
And in your current practice, you do not have a similar component of your practice as Dr. Sutter does for treating obesity and his weight loss program.
That's correct.
You mentioned that you have patients you treat for thyroid disorders. Did I understand that correctly?
That's correct.
What percentage of your patient census would you estimate that you treat for thyroid disorders?
That's hard to put in a percentage. I do a fair amount of thyroid therapy, but you got to remember my practice is very generalized, so it's hard for me to keep up with what percentage patients I have with chronic diseases.
Yes, sir. But would you guesstimate it at less than 10% of your patients that you treat for thyroid disorders?
Possible, but I can't answer that accurately.
And you reviewed the records of Dr. Sutter. Would you agree that your treatment of your patients who have a thyroid disorder is not the same type of treatment as Dr. Sutter employs?
I'd agree with that.
Just to summarize this, you don't have any specialized education, knowledge, or training in bariatrics or weight loss.
Correct.
You don't have any specialized education, knowledge, or training in hormone replacement therapy.
Correct.
You don't have any specialized education, knowledge, or training in treatment of thyroid issues.
Correct.
You don't have any experience or skill over that of the average family medicine physician in those areas of weight loss, hormone replacement, or thyroid issues.
I can't answer that question.
You've never reviewed medical records for any organization regarding weight loss or obesity, hormone replacement therapy, or treatment of thyroid disorders, or as any sort of reviewer, is what I mean.
No, I haven't.
You're not board certified in clinical pharmacology, are you?
No,
You're not board certified in applied pharmacology, are you?
no,
And you're not a practicing pharmacist.
that's correct.
Have you ever generated any peer-reviewed articles that were published on the issues of weight loss, hormone replacement, or thyroid treatment?
No,
How long have you been a family medicine physician?
32 years.
You mentioned the board certification in family practice. There's no other board certifications, correct?
That's correct.
You've never been accepted to testify as an expert witness by any court or administrative agency, have you?
I have not.
And you've never testified as an expert witness on the issues of weight loss, hormone replacement, or treatment of thyroid disorders in any capacity whatsoever.
I have not.
Have you taken any of the, well, let me back up. Have you satisfied the requirements of this board, the CME requirements for bariatricians?
No, I have not.
Do you have a generalized bias against bariatricians or physicians who treat weight loss?
No, I don't.
Are you active in either opposing or proposing a change in the regulations of this board regarding bariatrics?
I have no opinion on that.
Have you had recent communications with people, other physicians regarding the current bariatric regulations being considered by this board, the changes?
I have not.
Just to summarize, you have no specialized knowledge in those three fields of weight loss, treatment of thyroid disorder, or hormone replacement therapy, correct?
Right. I'm not board certified in any of those specialties.
And you don't practice in those areas other than what you said for the patients where you treat some thyroid disorders. And you don't know what percentage that is.
It's a lot of patients, but I don't know what percentage it has.
Thank you, Dr. Chance. Madam President, based upon the responses to the board our questions regarding the expertise or not of Dr. Chance in the areas at issue before this board today regarding Dr. Sutter and his practice, I object to him being recognized or utilized in any capacity, whether he calls himself a family medicine physician or he calls himself just a generalized practitioner, because he doesn't have what's required under Rule 1.9. Excuse me, let me find it. Under Part 2635, Chapter 8 of this board regulations, Rule 8.4, it states this: licensure and qualification requirements, except as otherwise provided by law, rule, or regulation of this state, any medical expert activity by a physician regarding a legal matter pending in a state or federal court or administrative agency in Mississippi must be performed by a physician who holds a current unrestricted medical license in Mississippi, another state or foreign jurisdiction, and who has the qualifications to serve as a medical expert on the issues in question by virtue of knowledge, skill, experience, training, or education. according to Dr. Chance's own testimony, he does not qualify as an expert on the issues that we have in this case regarding Dr. Sutter and his practice. So I ask that he not be accepted as an expert witness in this matter.
May I have some redirect on the board?
You may.
Dr. Chance,
Yes,
weight loss practice of medicine or hormone replacement therapy of medicine, is that practiced in isolation, or do those types of medicine affect the entire health of the individual?
it's more of a holistic clinical picture that we use. And, you know, I disagree with him saying that I shouldn't serve as an expert witness, and that, you know, I have experience, education, training, although not added qualifications in any of these three specific areas. But I treat patients who might be going to a bariatric physician, or, you know, somebody who's going to an endocrinologist, things of that nature, that I manage those conditions either with or without consultation from specialists.
And so they affect the entire health of the patient and affect conditions that you do routinely manage and treat in your practice as a family medicine physician. Is that right?
Yes.
I pose a motion that Dr. Chance is qualified in the areas that I have offered him. The fact that he does not specifically practice in the small club of weight loss physicians does not mean that he is not qualified as a physician to understand the effect that weight loss practice and the techniques and treatments and the effect they have on patients, such as lab values, such as the impact that multiple medications and treatments has on the patient, has on the patient's other conditions. Weight loss practice is a specialized practice, but it is not something that can be considered in isolation without regard to the entire patient. So I oppose the motion and ask that Dr. Chance be allowed to testify as an expert in the areas of family practice and general medicine. I absolutely agree that it will be a different perspective on those medical issues than you may receive from a family medicine, from a weight loss or hormone replacement therapy doctor who specializes only in those areas. That is one of the reasons that we particularly selected Dr. Chance to review these charts and to offer his opinions concerning Dr. Sutter's treatment of these patients.
What Mr. Barnes is saying is that any physician who has a patient is qualified to testify about expert issues of another physician's treatment because they affect the patient's health. So he's saying Dr. Chance is qualified to testify to psychiatric issues. He can testify, he can review a psychiatrist's records and say that psychiatrist is not treating him right because it affects the patient this way, or an internal medicine doctor, or an addictionologist, or pain medicine physician. He can say, well, you're not treating him right for pain medicine because it affects him this way. Sure, every treatment by every physician and every discipline affects the patient in some way, somehow. But Dr. Sutter specializes in the area. The regulation, this board regulation that I just read says he cannot testify unless he has that knowledge, skill, training, experience on the issues in the case. The issues in the case is whether or not Dr. Sutter has adhered to the standard of care in his treatment and whether or not he's broken the regulations. Dr. Chance is not qualified to opine as to whether or not Dr. Sutter has done anything to breach the standard of care or good medicine in the field that he practices in. So I ask that he not be accepted as an expert witness.
Although you tailored that motion instead of questions to Madam President for these proceedings, I am the one who rules on all motions in evidentiary matters. With that being said, I will hold my ruling until after lunch. Everyone be back here at 1 o'clock, including Dr. Chance. Thank you.
thank council for the board in light of the evidence and testimony presented this morning. We dismiss all charges against Dr. Sutter.
Council.
We have no objection.
You sure?
Well, ladies and gentlemen of the board, you've heard, is this a recommendation for the board to approve, or you were just dismissing this summarily?
Dismissing this summarily.
Gotcha. Okay. This concludes this matter at this time. If you all have any further questions, I guess please contact the executive director.
Thank you.
Thank you.
Trees now. I don't want to be intrusive. I've got these boxes over here. You want me to go ahead and get them now or try to get them later?
We need about 10 minutes.
Okay.
Yeah. Okay, thank you. Right, Madam President, come to your meeting. Next, Bubba.
How long we still in here? Everybody? All right, so keeping with our agenda, the next item is just to discuss or set the January board meeting dates. I think you all have received communication requesting that we have our January meeting on Wednesday, January 10th and Thursday, January 11th. So if you would, please check your calendars.
Is there any expectation that there'll be a 2-day board meeting like this past meeting? Can you say?
I would, think that chances are high that we would have to at least schedule for a 2-day meeting. As y'all have probably gathered, these are very hard things to predict and figure out. But with the level of I don't even know how to put it, just the way things are moving in the defense of charges and things like that, it seems that most of these hearings are going to become longer and longer and longer. So
that's combined with your ultimate efforts to limit the number of hearings. The number of hearings may not change or may go down, but the length of them.
I mean, you know, we can't always come to resolution, and that's when we have to go to hearing.
Yeah.
And obviously, if we haven't been able to come to resolution, there's some contention there that both sides think they're right.
Yeah.
And then it has the tendency to become a long drawn out hearing at that point. So I would just, this point moving forward, I would plan on all board meetings lasting 2 days. And we can look at alternatives. You know, if y'all want to do it, if y'all want to do the EC on Wednesday.
Excuse me, 1 second. Dr. Gersh. We're actually still, the meeting's not over. I'm sorry.
I'm sorry, the meeting's over.
It's not over yet. We're still in session. Thank you.
Sorry.
No worries.
Anyway, I would just say that we should plan on 2-day meetings. When we have the opportunity to cut them back, we will.
So does that seem to work with everyone? It's a little off of our routine schedule.
You don't think you could do it on the 11th? And then when you realize it's gonna be longer, move it to a 2-day? So that if it's just a 1-day deal, do it on the 11th? You don't think you would know in advance?
We have proven ourselves to be poor predictors of knowing in advance. So,
Yes, because I just thought a whole lot better.
You're saying do the board meetings on Wednesdays and go to Thursday if needed.
Yeah, I know, I understand that.
No, but I'm saying that what you're saying.
I'm saying schedule it for the 11th. And before the meeting, add Wednesday.
So, Mr. Breland, I think part of the difficulty with that, while it makes sense, there's a difficulty, I think, especially for the board members who are in clinical practice and even for those individuals who are otherwise engaged or in employment activities or other things. I think it sometimes is very difficult on short notice to add a day. It's a whole lot easier to take away a day. And so in the interest of being, I guess, a little bit more cautious and for people to be able to plan, it's usually easier. It's a whole lot easier to say, hey, I thought I was going to be in a meeting, but instead I'm going to be available, as opposed to for folks who have clinical practices to all of a sudden have to add a day or a half day. And for many people who are not local, they have significant distances to travel that may not really be amenable to a half day concept. So I think just in light of us being able to streamline things and knowing that when hearings do come up, it's usually because there's been a real concerted effort to come to an agreement and that agreement hadn't been reached, which means that people are going to probably need more time to get their issues out, that we probably should just plan so that everybody is expecting a 2-day meeting as opposed to a 1-day.
I'm just thinking out. That's fine.
I'm open
love
to
that.
suggestions. So, I mean, you know, if we start on Thursday and we can't finish, people could hang around till Friday, right? Or do we just stop and we wait till the next board meeting and pick back up a hearing? And then the information's kind of stale to the board members that they heard 2 months ago. You know, and there's not an easy solution.
I think that's a logistical nightmare too, when you think about coordination of witnesses and all those other things. I think having people to potentially need to be available for months at a time is a greater challenge.
Yeah, I mean, we're running into situations with more and more expert witnesses. And, we have to accommodate their schedules as well. And so these things have to be planned as far in advance as possible. It's just, it's logistically very difficult and we manage it the best we can. But I would stick with my earlier recommendation that just moving forward, we plan on 2-day meetings as a general rule. And to the extent that we can back them off, we'll try to let everybody know as soon as possible that we're going to be able to shorten things up.
So we would plan to move EC to the mornings on Wednesday. Okay. And that would leave us afternoons until or even mid-morning or.
Yeah.
Okay. All right. Any other questions, comments?
Did we ever make a decision on 10th and 11th? Is that
No,
okay?
I just wanted to see if anybody else had anything to say before I ask that question again. All right. So how are those days?
I'm going to be out of the country. I was prepared for that following week, but I won't be available. This is Rod Gibbons.
Yeah, your monthly out of the country excursion ride.
You tried around.
That's right.
Oh, gosh. Right,
should
their
all
passport
ride.
has to be 500 pages, about 500 pages long.
I feel, yeah, I've got the extended size one. Yeah.
All right. But everybody else we're good. So we'll have a quorum. I also want to say, Mr. Breland, since you brought that up, just a special thank you to our consumer members. We really appreciate you all being here and participating, and everything that you bring to this body. Thank you so much for your service. All right. That being said, I think it might be time for benediction. All right, so, if there is nothing else. Yeah. Let's take a, can I get a motion to adjourn, or can I just end it? All right, this meeting is adjourned.